Good afternoon. Firstly, I would like to thank the organizer for inviting me for this nice meeting, and then, of course, for giving me this so nice topic, SMA. The goal of my topic today is just firstly to share some data from clinical trials, and then to share with you our experience with gene therapy in SMA. As I already work in neuromuscular field for more than 20 years, I of course have some disclosures, so you can see them here. Before we start this topic, I know that everybody knows the cause of SMA. Just to summarize how the gene therapy works, we all know that there in SMA patient there is the gene defects, and the gene therapy replace these non-functional gene with human synthetic gene that's delivered by AAV9 viral vector. What was just so exciting in gene therapy is how the structure of the synthetic gene is done. So here is the structure of gene therapy in SMA, and there are different enhancers and promoters, and then the repetitive conclusion. So it's very unique structure. And then here are the overview of all clinical trials that are already completed or ongoing or planning future. I will just show you some data only from some clinical trials because there is not enough time to go through all these studies. But of course, you know the study START. It was the first one. Based on this study, the drug was registered. Then the SPRINT study, pre-symptomatic therapy, STRIVE study, SMA type 1 symptomatic patient, and then the long-term follow-up. But just would like to show you here that, of course, there are different way of administration. The clinical trials are ongoing. One is already completed, was published, the STRONG one, and one is recruiting, one is planned. So there is a different way of administration of gene therapy intrathecal. When we go to the SPRINT study, that's the study that SMA patient with 2 and 3 copies pre-symptomatically were included. Then this study had 2 cohorts, patient with 2 copies, 14 patient with 3 copies, 15. And we already have data more than 18 and 24 months to follow up. These are these 2 cohorts of patients. And what's important that only pre-symptomatic patients were included. So it's not a real world when we see newborns, because we already know that some newborns are already symptomatic. But in this study, all symptomatic patient newborns were excluded, and even patients that clinically may look asymptomatic but had already some electrophysiology changes, so had the CMAP at the baseline lower than 2 millivolts. Then the other exclusion criteria were the ventilation support during the daytime, and or if they have a tracheostomy, and of course then AAV9 antibody positive. The primary efficacy endpoint was different for 2 groups. 2 copies was independent sitting, for 3 copies independent standing. Then of course there were some secondary efficacy endpoint as a survival, then exploratory ventilation and feeding support, and of course we always have to be aware about the safety. When we look on the there is the baseline for both cohorts. The most important is really the day of administration, so otherwise the data are quite similar, but only in the patient with 3 SMN2 copies, the administration was a little bit in the later age, but really during the first 6 weeks of life. Of course, it's really nice to see data like this in a patient that we would predict type 1 or 2, that all patients does not need any ventilation support in the end of the study when you compare to natural history of SMA. When we look on the motor function in cohort with 2 SMN2 copies, again, quite nice results because all patients were able to sit independently more than 30 seconds in the end of the study. But when we look on the standing and walking ability in this patient, this is not 100%, but still something amazing for SMA. Mostly 80% of patients, 11 out of 14, were able to stand alone for more than 3 seconds, and 9 out of 14 were able to walk alone, something that you would never predict for SMA type 1. So very nice results. When you look on the cohort with 3 SMN2 copies, even better results. 100 patients were able to stand alone. 14 out of 15, just one patient not, but on time walking alone. And then sitting, when you compare with the endpoint for the SMA cohort with 2 copies, 14 out of 15 patients. So even better when the patient had 3 SMN2 copies. When we look on the safety, what's more important, there were no reports about serious adverse events that would be related to gene therapy. When we look on the STRIVE EU clinical trial results, in these results, patient type 1 were included. It was done in Europe. It was a cohort of 33 patients, and the median age at dosing was 4 months. And again, quite nice results. What's important, these patients were already symptomatic, and you can see that most of them achieve at least one motor milestones. When we look on the type of the motor milestones, of course, most of them achieve the head control, 23 out of 30, and 14 out of 32 were able to sit independently more than 10 seconds. Of course, we know that SMA type 1, they have quite early respiratory insufficiency. When you look on the pulmonary function in these patients, only one patient had ventilation support at 14 months after the therapy. So again, quite nice results in symptomatic patients. When we look on the cohort in US, it's important that they were different inclusion criteria and different final endpoints. But generally, you can nicely see again the effect of the therapy in symptomatic patients. Most of the patients, 85%, get the head control, 64 patients sitting without support, and 59% were able to roll from back to sides. So again, something that you would never predict in SMA type 1 patient. And of course, the question after therapy is how long the effectiveness will be here in gene therapy. So I just will share with you some data with the long-term follow-up. Until now, there are 2 studies with long data. One is from the START study, but I will show you the long-term follow-up data from the study type 2, where all patients with STRIVE were involved. Then SPRINT, the pre-symptomatic patient, and STRONG, this was the study with the intrathecal application. Here is what kind of patient were involved. So this is the cohort of IV administration, but there was a small cohort with intrathecal administration as well. And of course, here again, what's important, now we have almost like more than 3.5 years old follow-up data. And when we look on the sub-cohort, if we are in the IV SPRINT pre-symptomatic patient, we already have like 3.5 years old follow-up. And what's the most important is that the effectiveness is still there. So all patients keep their motor ability, and some of them are able to achieve new motor milestones. So it means that the long-term follow-up, the effect is still there, and some of the patients just learn new motor skills. When we look on the symptomatic patient, the situation is exactly the same. All of them just keep the motor ability, and some of them, even from the cohort with two SMA copies, they just get new motor ability. So in the long-term follow-up, the effect is there, and there is a probability that they can improve in the motor function. Which of course is a little bit difficult when you look on this cohort that some of the patients are already in combination therapy. That's the real world. That the families and patients are pushing us as a clinician to get more and more therapies. But most of the patients that were involved in this long-term follow-up, they were only in one therapy, the gene therapy. When we look on the ventilation and feeding support, the presymptomatic cohort is just perfect. There is no patient that would need in the long-term follow-up ventilation support or some feeding support. Of course, when you look on the symptomatic patient, the story is absolutely different, and we know it from the real world, that if you treat symptomatic patient, you will never cure them. Of course, you can stabilize them and improve them. But in this patient, again, I would say that the results are quite nice. You can have in your head that these are the patients with type 1, because they have only 2 SMN2 copies, and in the long-term follow-up, after 3.5 years, almost 70% of patients did not require ventilation support. So it's really amazing numbers. And when you look on the feeding support, again, quite a good number of patients did not require feeding support. So very nice results. And in the long-term follow-up safety, again, there are no new severe adverse events that would be related to gene therapy. Of course, these patients, especially the symptomatic patient, can have some complication like pneumonia or just the classical pediatric diseases, but they were never related to gene therapy. So when we summarize the long-term follow-up, we can be sure based on these data, and it's, as I said, almost in all cohorts, 3.5 years follow-up, that the motor milestones are still there. And then in some small sub-cohort, they can achieve new motor milestones after, during the long-term follow-up. Then the ventilation, again, is quite stable, and the feeding support as well. So very nice data that show us that the gene therapy is effective, and it's effective for long term. But I just would like to share our experience, and then just to emphasize some point that I think are really important in dealing with gene therapy in pediatric SMA patients. I'm from Czech Republic. Czech Republic is just a small country in the middle of Europe. We are 10 million inhabitants, so nothing compared to Egypt, but our situation in SMA causal therapy field is very ideal because we have reimbursement for all 3 therapies, and the indication criteria for reimbursement are quite broad. So we can use gene therapy for all patients, doesn't matter type of SMA, until the age of 3 years, with lower weight than 13.5 kilo. The only exclusion criteria is internal status, and we can just discuss why we exclude 2 patients from gene therapy. Then nusinersen we use for all type, doesn't matter severity or age. And risdiplam we use for all type except type 4. And there is one news from this Tuesday that in Europe now we can use risdiplam for newborns as well. So this is just EMA. There's news from EMA from this week. And then, of course, the most important, what we have learned in this new situation was that, of course, all pediatric neurologists say, or just neurologists would say, SMA therapy is effective, and we need, and as a SMA patient, we understand that everybody has to want to get this therapy. But the reality is sometimes different, and this is really the most important, to be able to change the system and to get the reimbursement for your patient. And in Czech, we were quite lucky because the stakeholders and regulators really follow our recommendation as a pediatric neurology society. And what help us in gene therapy, that there are some international recommendation. There is one consensus statement on gene replacement therapy. And this topic now is getting to be changed. So there will be new version of this recommendation in few months that we may broader the indication criteria for gene therapy. So this is really important, just to have some international recommendation when you just go to your stakeholders, regulators, to be able to change the rules. And here you can see the cohort of our patient that we treat by gene therapy. Now we had like 31 patients that we treated by gene therapy. And because the nusinersen was the first drug in our market, there are quite a lot of switches. So we did quite a lot of switches from nusinersen to gene therapy. And mostly the most frequent reason why we did the switch was that it's a one-time therapy. Okay, that the family, and of course the wish of the family, but then really the quality of life, because it's a one-time therapy, we decided to do the switch. And then there is increasing number of the first-line therapy, and especially in newborns now in Czech Republic. Here you can see the demographic data. So we can treat all type of SMA, type 1, 2, 3. And then the weight, until now we have the weight limit, but this is something that I think would be shortly changed, but there is undergoing discussion. So for us is the limit 13.5 kilo and 3 years of age. Here you can just see the improvement in the physio scales, and the subcohort of patients that were previously treated by nusinersen. We know that when we use the causal therapy in SMA, there is quite nice, especially in these young children. Of course, it's different when you treat adults, but in the young children, you can really see the nice improvement during the first 3, 6, even 12 months, and then it looks that there is a stabilization. And of course, our data are not big because we have only the subcohort of 11 patients followed more than 1 year after gene therapy, but you can see that even there were already the stabilization, the gene therapy improved these patients in physio scales. And when you look on the cohort of therapy-naive patient, of course, again, nicely show the improvement. I think that there won't be anybody, again, between us that would say that the drug is not effective. Of course, we all of us know that it's really effective drug. But sometimes when you see this quite big improvement in your patient, it is just so amazing. When we look on the bulbar function in our cohort, again, quite nice results. All of our patients were stable after gene therapy. Of course, our patients are this is quite small cohort, but there were no patient that would need some some support with feeding after the gene therapy. After 1 year, the gene therapy was administered. But when we look on the respiratory function, of course, our group is small, but there is some improvement after starting the therapy. And even in the cohort of patients that were previously treated by nusinersen, now we had like one patient that withdraw the BiPAP, and one is ongoing the withdrawing. So small cohort of patients, but we can clearly see that in some patients there can be improvement after the switch from nusinersen to gene therapy. And now I just would like to share some of our cases. The first case is very severe SMA type 1. The first symptoms was before the age of 6 weeks. And the first therapy, of course, because of the time when the child was diagnosed and the drug was not yet approved in Czech, was treated by nusinersen, and then at the age of 1 was switched to gene therapy. And before the switch, you can clearly see that the phenotype is quite severe. But CHOP was 42 points. And after 2 years of gene therapy, this child is able to use the wheelchair independently and sit independently. So it's again quite achievement in patient with so severe phenotype SMA type 1. Then some cases with SMA type 2. Again, what's important in this case is the first symptoms and start of the therapy. Because it's a type 2 that symptoms already started before the age of 1 year, but this child was diagnosed quite late, and the therapy started in quite late age, 15 months. Then firstly received nusinersen, and then got gene therapy. It was our first patient that got the gene therapy before the drug was approved in Europe. So it was quite exciting time for us. And the family is very satisfied with the results, because before the gene therapy, the boy was not able to sit independently. And after 1 year, he was just able to stand up and stay with some support. And now, 2 years after therapy, he's able just with support to do few steps, okay? So type 2, already able to stay independently and do only few steps. It's of course not walking with support. But when you look on this case, similar case, because type 2, 3 SMN2 copies, but he was more lucky because the diagnosis was done earlier at the age of 9 months. And then he already started the therapy just after the diagnosis. But similar story, firstly nusinersen, then switched to a gene therapy. Before the gene therapy, he was already able to sit with support and stand with support. But what's the most important here, you can see that he's able to walk independently. Of course, it's not a normal way of walking, but type 2 able to walk. So we have two similar cases with type 2, and I think it's really the most important difference is the age when they were diagnosed and when they start the therapy. From these two cases, you really see that the most important is just to diagnose the symptomatic patient, diagnose them as soon as possible, and start the therapy. It doesn't matter what kind of causal therapy, as soon as you can. And this is the most important, when before you start the therapy, to speak to the parents, to have the realistic expectation, because you really cannot cure this patient. You can stabilize them, you can improve them a little bit, but you cannot cure them. And because you cannot cure them, all of them will need standard of care of the symptomatic therapy. And it's really like, I cannot say how many percent is it, but I would really see that like can be half of the effect of the therapy. It's not only about one gene therapy and that's it. No, the story is not ended. And we need to provide very like good and high quality of symptomatic care. And there are already published a standard of care, how we should look after this patient. The question is that these standard of care were published at the 2017 before the gene therapy was used. And what I would like to show you after, that maybe we would need to change the standard of care because the phenotypes look different than before. But here you can see our multidisciplinary care in our hospital. Of course, we have the advantage that I work in one of the biggest hospital in middle of Europe. So we have, this is really the white building is the pediatric part. We have all specialization in one building. And it's easier to have to provide the multidisciplinary care. But this is really important to set up these teams. And I know how difficult it can be to start from zero, to just go to visit the first the cardiologist for first time to try to emphasize him for this topic. In SMA, we use the team that we previously used in DMD, in Duchenne boys, because really the SMA was not so frequent in our clinic before the therapy as DMD boys. But what's important that because of gene therapy, we had to increase the specialization in our team. We really newly involved the hepatologists because of the side effect, mostly in the treatment of the symptomatic patient. No, newborns, when you treat newborns, there are not so many side effects. And then hematologists and hemato-oncologists, because there are really some side effects that we are, as a pediatric neurology, we are not used to this used to this complication, and these new people help us to solve the new situation. So again, the video you already saw, the patient with type 2 already walking. And in his case, I just would like to show that maybe there is a need for changing the standard of care, because these new phenotypes need different therapy. For example, the hip problems. Of course, if you have a patient at the age of 15 months that it's not standing and walking, then the development of hips would not be normal, okay? Because the verticalization was not normal, so the hips for sure would have some kind of dislocation, as you can see here in this X-ray. So we have to be aware about this. So if there is no proper verticalization during the first 2 years of life, there would be for sure hip problems, would be different than a cerebral palsy, of course, because the phenotype is different. We can do something in prevention. We can use the splints. And then, of course, there is the discussion ongoing now about the surgery. But there is no standard of care, but what I would recommend, our experience is that maybe there is a time to postpone the operation until the age of 5, 6 years, because like to do it earlier, there can be quite a lot of complication, as this child at the age of 2 years was operated, and after that as the synthesis failed and was quite a lot of complication. So maybe really just to do the proper prevention, physio, and then do the operation before the age of 5, 6. The other problem is scoliosis. We know that the therapy is effective, but there are still many questions why some muscles are in some muscle groups is more effective than the others. And for sure, the axial muscles after any causal therapy are weaker than the muscles in extremities. and it leads to higher frequency of scoliosis. And again, there should be some prevention. And then, of course, in some cases, there is a need for scoliosis surgery, even in the earlier stage and age than we were used to in the classical SMA. But the most important topic in SMA is really the time. You know, that's a progressive disease, and then the neurons, especially in the type 1 and 2, are just, the patient lose them very quickly. So we need newborn screening. And in Europe, the situation it's not ideal, but quite good. And I'm quite happy that I can show, oh, okay, will be later. So the newborn screening is already set up in some countries. And what's important to know that even there is a newborn screening, the SMA will not be eradicated because the methodology can diagnose only the homozygous deletion, not the point mutation, okay? So just keep in mind that even newborn screening, still some of the SMA patients will be born and symptomatic, but the diagnosis would be ultra rare. What we would be glad and we would expect from newborn screening, if we treat pre-symptomatic patients, that we just hope that all will be quite healthy, but it's not the reality. And we know it already from some clinical trials. This is the ideal case that this patient has 3 SMN2 copies, and as you can see here in this video, in his age 18 months, it's just absolutely healthy child. It's just so nice story, especially in families when they already have some symptomatic SMA patient. So they really appreciate the new time that we are living, that they can have absolutely healthy patient with same gene defects. So this is really nice story. There's the ideal world, but we have to be aware that even the data from clinical trial that I already show you, then these patients were asymptomatic when they were included in this study, but they were not healthy, like not normal, during the follow-up. So especially the cohort with 2 SMN2 copies, if you would have a set up the newborn screening, the time is really important. And the discussion with the families as well important, that there may be some deficit even in the newborn screening. And then from our experience already, we know that some of the patients after the birth, even diagnosed with newborn screenings, are already symptomatic. So the perspective of this patient would be even worse than from the clinical trial. So the newborn screening does not mean that there won't be any symptomatic SMA patient. And we already had one severely affected newborn that we decided to go through by the palliative care. So it's really important to set up the newborn screening, but again, the realistic expectation is as well important as in treating the symptomatic patient. And the future, the story is not yet ended with SMA, because there are many questions. Of course, for me, the most interesting question is still the pathophysiology of SMA, because we still don't know, we don't understand how the SMA, what are the reasons, how the pathophysiology in the motor neurons is. So this is really interesting that we already know how to treat the disease, but we don't know how the disease starts. But from the practical point of view, of course, the most frequent question that our patient give us is if the combination therapy would be more effective than only the monotherapy. Until now, in Czech, we don't combine the therapies. And the problem is, of course, the money. If the therapy would be without any money, then we may consider it, but because of the money and because of the lack of information that were already published. Until now, we don't combine, but of course, in the future, I think that can be changed because there are already clinical trials that do the combination therapy, and we need to wait for the results. The other question, of course, if some of the patient would benefit more from different type of causal therapy, again, something that we still don't know, then maybe yes, why not? Because, of course, every therapy is different, so maybe there would be some subgroup that would more benefit from different type of therapy. Of course, the side effects are most important in the gene therapy to consider it if the side effects does not overweight the effect of the therapy. And what I think that there is really a need for new standard of care because there are new challenges with the new phenotype. I just show you the hip dislocation or scoliosis, but there is again question with some behavior abnormality in SMA type 1 patient. You may just already known that it seems that there is a higher frequency of autistic spectrum in these patients. So there are many new questions about the SMA. And yeah, this is the last question here. So there may be higher neurodevelopment comorbidity in SMA type 1. And because there are so many questions, I think really the international collaboration is the most important thing. We really need to collaborate all together. We need to get in touch in meetings like today to discuss the cases from the real world, to try to get the best therapy for our patient. And this is just the example of activities ongoing in Europe. So you can see that really the SMA newborn screening is just so important topic and brings new questions how to discuss this topic with patients and so on and families. But I think that the best now organization in Europe is the EuroNMD network, but many other patient organization, of course, and Treat NMD, but it's the world organization now. So the collaboration is really crucial. So to summarize my talk, we are just so lucky as a pediatric, but I think adult neurologist as well, that we have causal therapy for SMA. But we need newborn screening because the time is the crucial factor of effectiveness of this therapy. But if you treat symptomatic patient, you have to be aware that therapy is only part of the effect. The second and really important part is the symptomatic care that need the multidisciplinarity, and it's quite difficult to set up the center, but it's important for your patient. There are so many uncertainties. I think that really always when you get new therapy, just open new doors, and then there are new questions, and that's why the international collaboration is really important. And then we, as a community, need to be able to communicate, and the most important is always to write everything, to publish it, because what's not published, then nobody believes. So publish whatever you think is important and you see in your patient. So thank you for your attention. Of course, we'll appreciate any comments or questions. Thank you.
Many thanks, Professor Jana, for a nice and short lecture, but was large and great effort behind it. Many thanks again. Can we open the floor for questions?
Thank you, Dr. Jana, so much for very impressive patients. And you are right, we must treat early, whether type 1 or type 2 or even pre-symptomatic. But we have patients with gene therapy. They show rapid improvement at first, then plateau. Then the family will ask, we need more. We need to add other therapies. What's your opinion?
That's, as I show you, that's really the most frequent question that we get in clinic, because all therapies, they just improved, and I always think like, great, there are some gray motor neurons, they just get function, and then that's it. There, you cannot, if you look on the physiology of the disease, so then there cannot be other improvement. Of course, there is an improvement with age, because when the child is before the age of 6 years, they are still getting clever and able to keep the handicap better, so they improve in the scales, but it's not because of the drug, but because of the normal natural development. So it's difficult. I understand the families that they want the best for their child, but there should be some international recommendation, and until now we follow the European one, that the combination therapy is not more effective. So we try to explain to our parents that this is the real situation, and we have to wait until we will have more data from clinical trials, and the trials are ongoing. This is really good. So that then may change these reimbursement rules. And then, of course, there would be the question if they say, okay, but I can pay by myself, but then in Czech Republic, I cannot do the differences. So I would not prescribe for patient only because of the money, because I am doctor and I don't want to do the differences. So I don't prescribe the therapy, even the family has enough money to pay for it.
You mentioned that we give inclusion criteria now in Czech of elder children up to 3 years only, or 5 years and weight 21 kilograms.
The gene therapy. Until now,
gene therapy, yes.
Yeah, until now we have like the younger than 3 years and 13.5 kilo. But as I mentioned, there is the European consensus for gene therapy, and now there will be we publish new version that would be more open for heavier patient and older. So there would be ongoing discussion how to change it in Czech Republic. And I think that maybe really there is a time already to open it for heavier and maybe older patient, but we should be really aware that these patients would have more probability of side effects, and to follow them properly after the gene therapy. Again, this is a very important thing that I not mentioned during the talk, that after the gene therapy there should be proper follow-up. That I remember some tourisms that they just got the therapy, and after 2, 3, 4 weeks they were just sent back to their country. So this is not the proper one. You really need at least 3 months, and for sure I think that ideally is longer. So this is really important.
Professor, thank you for the presentation. I want to ask about the criteria, clinical criteria, or the time factor after which you shifted your patients. Because you mentioned in the second patient that he received 5 doses of nusinersen before shifting to gene therapy. And we followed him up after 1 year of gene therapy, and 5 doses of nusinersen is not 1 year treatment. So I am asking why we shift this patient after only 6 months. I think 5 doses equals to 6 months treatment of the gene modifier.
Yeah. Because these patients started therapy when the gene therapy was not yet reimbursed in Czech Republic. So this is everything about the reimbursement. So gene therapy in Europe is registered by May 2020. Okay, but this child was diagnosed and started therapy before. And in that time, there were only nusinersen. There was just only nusinersen in the market. So all SMA patients in Czech were on nusinersen. And then new drug came in the market, and of course the family started to ask us if they can do the switch. And we think that because it's a one-time therapy, and of course the quality of life after one-time therapy is higher than just to be follow-up for the whole life, we decided that if the patient would be suitable and the family would ask us for gene therapy, then we do the switch.
But there wasn't a clinical criteria for this shifting. It was
We
only
don't have
because
any criteria for shifting. We just, but what we, in that time, now I think that maybe it's not necessary, but in that time there was only one paper, German paper, that they just predict that maybe there should be 1 month between the last nusinersen injection and gene therapy that may decrease the frequency of side effects. So in that time we follow this article and we wait 1 month. But now we are not in the same situation anymore because all patients are already treated. But maybe I'm not sure about this criterion that it's really 1 month is something that you have to necessarily keep.
I mean, from your point of view, if this patient wasn't asked for gene therapy and we continued the nusinersen for 1 year, do you believe he will have the same milestones sitting after 1 year?
This is like there are not enough data. Okay, we don't have enough data to prove it. Until now, we think that all 3 causal therapies are similarly effective. In these small cohorts, you can see some differences, but of course, it's just small cohorts and not enough data. So when I speak to families, I always say that we have 3, like in Czech, 3 causal therapies, and we believe, based on our knowledge nowadays, that the effectiveness is similar. But of course, the quality of life in one-time therapy is something that, especially like in newborns in Czech, like all families finally decided to get 1 gene therapy.
Thank you.
Professor Jana, thank you very much for your interesting talk. I would like to ask you a question, please. In your experience, what about sick infants, sick babies on ventilator? Did you start any of even the gene modifiers for those patients, or you just wait until they get off this critical period?
So we would not exclude any patient from risdiplam or nusinersen if the family would like to. Okay, so because we know that even patient with ventilator, they can live for a long time and can, from their point of view, can have quite high quality of life. So we would not exclude any patient from causal therapy. But what we have already done, we exclude 2 patients from gene therapy because of internal status, because of infection, chronic infection. One had firstly acute ABV infection, then quite a lot of pneumonia. So we exclude 2 patients because of internal status from gene therapy. But the reason was that in these children, we think that the risk for side effects is higher than the probable benefit, because we know that, as I said, we believe that all 3 therapies are effective. So we think that if there is an increased risk for the side effects, especially like the chronically ill patient or some acute, like the EBV infection, whatever, then we can use some other causal therapy.
But what, the other 2 therapies,
yes,
we can use them?
Yeah, we use them.
Thank you.
Last question.
But of course, I remember one family, they decided to stop the causal therapy and to go for palliative care. The only one family, and until now we follow more than 80 SMA patients, and one decided to stop nusinersen therapy and just start palliative care. It can happen, it's always after the discussion with families, and really the palliative team is part of our multidisciplinary team in the severe affected patient.
Professor, please, last question. How certain are we about the related chromosomal integration? You know, supposedly gene therapy was very safe in terms of not being integrated, the viral vector is not going to be integrated in the genome. But now with the widened use of the gene therapy in other neuromuscular diseases, like recently the Duchenne, voices have surfaced about how certain are we about the chromosomal integration. What do you think about this?
How certain? So we have to, we are based on the publication and information. Okay, from our patient, we don't have any suspicion of any type of changes now. And of course, everything what was published does not show any signs of integration. So, but of course, this is always like when we speak to the parents and really the discussion is just so important, then we tell them that we have some uncertainty because the gene therapy is here for more than 8 years, but of course what would happen after 15 years, we still don't know.